Good afternoon. I'm Meg Jardine from the University of Sydney, and I'm a member of the KDIGO Guidelines Group Executive Committee. I'd like to thank the Chinese Society of Nephrology for inviting me to talk with you today about the management of high potassiums. These are my disclosures. Everything I'm presenting today is the sum of a controversies conference that was organised by KDIGO in 2018. As a result of that conference and the work groups that worked within it, we produced this paper, which is published in the Kidney International Journal and is available online for free download on the KDIGO website. It's worth reminding ourselves of the normal handling of potassium in the body in the well state. Potassium is the most abundant cation in the body, and most of it is held in the intracellular fluid, within the muscle cells in particular. There is a minority held in the extracellular fluid, and the gradient between the two is critical for normal bodily function. That applies particularly to the excitable organs, the skeletal muscle, the myocardial muscle, and particularly the neurons. There's a wide variation in intake, but on average, there's an intake of around 100 millimoles of potassium per day, and most of this is lost through the kidney, with only around 5 millimoles per day being lost through the feces. In the healthy state, potassium homeostasis is tightly regulated, and the body is able to maintain the extracellular to intracellular potassium gradients despite a very wide variability in potassium intake. Acutely, the extracellular to intracellular shifts are mediated by insulin and by beta-adrenergic mechanisms. In the chronic state, the kidney comes into play. It regulates potassium homeostasis via potassium excretion in the distal nephron, and that's largely mediated by aldosterone, which works at multiple levels. The whole system works exquisitely well as long as kidney function is largely intact. The Controversies Conference came up with a hyperkalemia classification, which is simple and can be used for research or for comparison purposes. It includes both the potassium concentration itself and the presence or absence of ECG changes. A potassium level of 5 to 5.9 would be graded as mild in the absence of ECG changes, but would be moderate hyperkalemia if ECG changes are present. A potassium of 6 to 6.4 is graded as moderate in the absence of ECG changes, or severe if they are present. And a potassium of greater than 6.5 is regarded as severe, regardless of the ECG changes. The risk factors for hyperkalemia are chronic kidney disease and other comorbidities, diabetes and heart failure. Dietary intake plays a role. Medications also can be a risk factor. The potassium-sparing diuretics, any inhibitors of the renin-angiotensin-aldosterone system, calcineurin inhibitors, cyclosporin and tacrolimus, potassium supplements, of course, and it's worth thinking of hidden potassium, such as in potassium-containing salt substitutes, and non-steroidals. Of all these risk factors, far and away the greatest risk factor is the presence of chronic kidney disease. In this analysis from the SCREAM project, which is an observational cohort analysis of adult healthcare users in Stockholm, over 364,000 people were surveyed who had undergone potassium testing during 2009. And the incidence of hyperkalemia was estimated over a 3-year observation period. You can see that in this survey, increasing age increases your risk of hyperkalemia. The presence of type 2 diabetes increases hyperkalemia. Myocardial infarction or a heart failure history increase hyperkalemia, as does being on a RAS blocker. But the greatest predictor of hyperkalemia is impaired renal function. Grade 3 renal function, that's an eGFR of 30 to 60, have an incidence of around 20%, and that incidence rises markedly if a grade 4 or more is present. That's an eGFR of 30 or less. Of course, there is a wide range in potassium levels. even at any given EGFR level. We can see that in this information from the CKD Prognosis Consortium, who've mapped the potassiums according to CKD stage. In the black, you can see people with an EGFR of 60 or more, and their potassiums range with a mean and a mode of a little less than 4.5 and a wide distribution, with some individuals having very low or very high potassiums. For people with grade 4 disease, EGFR 30 to 59, the mean is a little higher, and there's also a broader distribution with a general right shift, so fewer people with low potassiums and more with high potassiums. And then for people with an EGFR of less than 30, again, the mode is reasonably similar, but again, a right shift so that we've got more representation of the high potassiums. If we look at a cutoff potassium of 5.5, you can see to the right of that line that there are many more individuals with impaired EGFR represented there than there are with normal EGFRs. So what are the associations of abnormal potassium levels? In this large data graph, you can see that compared with the normal range for potassium of 4 to 5, low potassiums and high potassiums are both associated with increased mortality. And in fact, this is how we derive the normal range. It's in fact the healthiest range. This, of course, doesn't prove as causation. There may be many reasons why people have a low or high potassium, such as other disease states, malnutrition, other medications, and these may be the factors that are on the causal pathway to the high mortality. But nonetheless, abnormalities signify a group that are at risk. This is not purely the result of chronic kidney disease. In this analysis, the mortality association was examined within EGFR bands. And you can see that for people with grade 1 to 2, that's an EGFR of greater than 60, there is still that U-shaped association with mortality, as there is for higher grades of chronic kidney disease. At higher levels of chronic kidney disease, the association is not as strong, but it is there nonetheless, showing that abnormal potassium signify worse prognosis at any EGFR. So we'll now move on to the management of hyperkalemia. And it's worth bearing in mind the distinction between our responses to acute hyperkalemia and how we manage chronically elevated potassium levels. For acute hyperkalemia, we stabilise the cell membrane and then reduce the serum potassium in the extracellular space by redistributing into the cells and by endeavouring to eliminate the potassium from the body. For chronic hyperkalemia, we can look at dietary interventions. We should be aware of risk factors and make sure that any protective medications and other measures are in place. We can look at decreased uptake through the gastrointestinal tract and increased excretion, again through the gastrointestinal tract or the kidney. So firstly, we'll talk about the management of acute hyperkalemia. There are three main concepts: membrane stabilisation, shifting of potassium, and then eliminating of potassium. And we'll go through each of these one by one. In the KDIGO Controversies Conference report, there's a schematic that will help guide you through step by step the management of acute hyperkalemia. We'll talk about each of those components as we go. So the first thing in acute management is to look for ECG changes. Certainly look for it in outpatients with a potassium of greater than 6, or look for potassium levels in anyone with new ECG changes. And if concerned, refer to your emergency department for monitoring and therapy. Whilst there, we monitor patients for their vital signs and put in place continuous cardiac monitoring to monitor the ECG until the potassium is normalised. A 12-lead ECG is helpful. First step is to stabilise the membrane. The ECG changes you might see with a potassium of 5.5 to 6.5 include tall peaked T waves. As the potassium rises, the T waves remain peaked and the PR interval can be prolonged. The amplitude of the P waves is reduced and the QRS complex is widened. And then at very high levels of potassium, we may see an absence of P-wave. We see intraventricular blocks, bundle branch blocks, and widening of the QRS complex, so that the ECG pattern morphs into a sine wave, which can be a predecessor to ventricular fibrillation or asystole. But there are pitfalls in relying on ECG. One is the scarcity of evidence. But from what we do know, up to 50% of people with high potassium levels can have a normal ECG. So it is critical that you monitor the serum potassium as well as the ECG. The other problem is that there's no correlation between the presence of T-wave changes and the potassium itself. So again, it's important to have both the ECG and a serum or plasma potassium. So you've now placed your patient on a cardiac monitor with a 12-lead ECG and looked for ECG changes. If they are present, you're going to want to stabilise the cardiac membrane and give them IV calcium. You can give either 10 mL of 10% calcium gluconate or 10 mL of 10% calcium chloride. And you should consider repeat dosing if after 5 minutes the ECG changes persist. There's some guidance in the European Resuscitation Council. The initial dose there is 10 mL of 10%, which can be repeated. They warn you to watch and continue monitoring the patient because calcium can slow the heart rate and itself precipitate arrhythmias. They also remind us not to give calcium and sodium bicarbonate at the same route at the same time because it can precipitate. So having stabilised the membrane, we move on to the second step of acute hyperkalemia management, and that's potassium shift. And we use this to lower the potassium in the extracellular space. A reminder that this potassium lowering, this shifting, is transient. So we need to then be thinking about the next step. At this step also, we are confirming hyperkalemia. We repeat the potassium measure to exclude pseudo-hyperkalemia or hemolysis and take the potassium with as least trauma to the cells as possible by avoiding using tourniquets or fist clenching. It's also wise to get the specimen to the lab as soon as you can to avoid the sample sitting around, which again can lead to cell lysis and artifactual potassium elevations. So in this step of redistributing, we want to move the potassium into the intracellular space to bias time. We can do this using beta-2 receptor agonists, insulin and glucose, or sodium bicarbonate. And then we remove the body either through diuretics, acting through the kidney excretion pathway, through potassium binders that will excrete potassium through the gastrointestinal tract, or through extracorporeal methods, hemodialysis or peritoneal dialysis. I'll say a few words about salbutamol. There's a systematic review on the use of salbutamol on the Cochrane database website. It found that 10 and 20 milligrams of salbutamol does result in significant potassium reduction. However, no studies reported on whether adverse patient outcomes were reduced. The review also noticed the evidence base is small. There was a total of 247 patients only across 7 studies. The side effects noted in that report are an increase in heart rate, tremors, palpitations, and anxiety. Salbutamol and insulin are being compared in a study that's ongoing. The INSACA trial is being run in emergency departments in France. In that trial, people with a potassium of 6 or greater are being randomised to either 10 milligrams of nebulized salbutamol, 10 units of short-acting insulin with 500 mL of 10% glucose, or 10 units of short-acting insulin, 500 mL of 10% glucose, and 10 mL of nebulized salbutamol. So in this study, the standard of care would be regarded as insulin and glucose, and we're going to be able to see the effect of the alternative of salbutamol or the add-on of salbutamol. And that study's been recruiting for around a year. So now the third step, after you've shifted potassium into the cells through mechanisms such as insulin and glucose, is to definitively remove some potassium from the body. The definitive solutions include dialysis, which you might use in people with advanced chronic kidney disease, loop diuretics, which might be effective in people who have sufficient renal function, or potassium binders. In advanced chronic kidney disease, we'll be considering dialysis, as loop diuretics are likely to be relatively ineffective. In patients who receive dialysis, be on the watch for rebound hyperkalemia. There's one retrospective analysis of emergency department patients with potassiums of greater than 5.3. In those patients, after treated with hemodialysis, recurrent hyperkalemia occurred in a third, although only 15% with recurrent dialysis. And then after this elimination step, in the longer term, it's worth performing a critical review of the medications and looking in particular for any that might be contributing to the high potassium levels. You could consider temporary discontinuation of RAS inhibitors, look for underlying conditions that may have precipitated this, particularly hematological, and give the patient dietary instructions, particularly if they have chronic kidney disease. So we'll now turn to the management of people with chronically elevated potassium levels. There are a number of management options. Many of them do not have strong evidence. A dietary change is one mechanism, but we have to be careful of the potential for harm and for inadvertent malnutrition if a diet is excessively restricted. Some people have talked about a permissive approach, where the potassium levels are tolerated, although this is not studied and we don't know the outcomes associated with this approach. You certainly should review medications, particularly those predisposing to high potassium levels, and consider using a potassium wasting diuretic in the chronic state. Some of the removal of the potassium from the body is through the gastrointestinal tract, and so possibly there's a role for laxatives, with one small study being published on that subject. It's worth correcting any coincident acidosis. More frequent dialysis might be appropriate for dialysis patients, and in particular adjustments in the potassium bath. SPS is a consideration which I'll turn to in a moment. Very small evidence for that practice. And then more recently, there have been potassium binders for which there are large randomised trials. So we'll touch on some of those. Potassium shift. Sodium bicarbonate may help to chronically shift potassium from the extracellular to the intracellular space. It can be considered in patients with acidosis. There is, though, very little data on the consequences for potassium levels and for clinical events, and you should certainly use this approach with caution in patients with volume overload because of the sodium component. Now, heart failure is one of the risk factors for hyperkalemia, so this is a very real consideration in some patients. Another option is to use the non-potassium sparing diuretics. Loop diuretics may be used, may be beneficial perhaps in people with hyperkalemia and volume overload. The non-potassium sparing diuretics, such as the thiazides, will reduce potassium. On the right, you can see a graph that shows reductions in potassium that increase as dose increases for hydrochlorothiazide and for chlorthalidone. And now moving to gastrointestinal approaches to eliminate potassium. There are essentially three different potassium binders. Sodium polystyrene sulfonate, SPS, which is a very old medication, sodium zirconium cyclosilicate, and pitfalls. Sodium polystyrene sulfonate, SPS, which has a brand name of K-exolate, binds potassium in the gut. It's a very old medication, and so the level of evidence is sparse. Adverse events include intestinal ischemia and ulcers and perforation, and we'll speak about that in a moment. Pitfalls is one of the newer potassium binders. Brand name is Veltassa. It has no sodium content. and its adverse effects include constipation in 7%, hypomagnesemia in 5.3%, diarrhea in around 5%, and low potassiums in 1.5%. Sodium zirconium cyclosilicate, or LACELMA, binds potassium in the gut again. It's highly selective. Side effects include edema, which occurs in nearly 14%, high blood pressure, which occurs in 11%, urinary tract infections in 8%, and low potassium in 10%. So turning to the evidence for efficacy, how well these agents work at binding potassium. So for SBS, there's only 3 small trials in total. One of them randomised 33 outpatients with mild hyperkalemia, potassiums between 5 and 5.9. It was a double-blind randomised trial and studied the effect of 30 grams of SBS or placebo once a day for 7 days. What that study showed was that there was a clear reduction in potassium. The SBS treated group had around 1 millimole drop in potassium compared to the placebo group. Now, the common side effects of SBS are well known and are relatively minor. They include loss of appetite, stomach discomfort, nausea, vomiting, and constipation. And by and large, these reverse when the agent is ceased. More serious harms, though, are colonic necrosis. Most reports of colonic necrosis occur in conjunction with sorbitol. So it is now advised not to use SBS with sorbitol. It's been hard to know whether this is a true association or not because it is such a rare event. And SBS is so old that it predates the era of the large randomised trial. The Canadians have looked at this in a large population-based retrospective cohort study conducted in Ontario, Canada. In that study, they looked at all adults over the age of 66 for whom prescribing information was available between 1995 and 2015. They looked for all episodes where SBS was prescribed and where laboratory values were available and identified a little over 7,500 people out of a population of nearly 2 million. In this group who'd received SBS, the mean eGFR was nearly 45 mils a minute and the mean potassium was 5.6. What they found was that there was an increased hazard ratio for the occurrence of any adverse gastrointestinal effect, with a hazard ratio of 1.26, so a roughly 25%. They looked specifically at gastrointestinal ulceration and perforation, and that was clearly increased with a hazard ratio of 1.56, and separately looked at intestinal ischemia or abdominal surgery, and the rates there were similar. Then moving on now to the novel potassium binders. Patiromer has been tested in a large randomised trial and clearly reduces potassium. Similarly, sodium zirconium cyclosilicate again reduces potassium. On the right, you see reductions in everyone on drug and then randomisation to continuation or placebo. And clearly, the potassium remains reduced in those on treatment until the end of study when all patients were taken off. So both of these drugs have been shown to be effective at reducing potassium, and their side effects are by and large tolerable, as I've showed you in an earlier trial. What is yet to be established is what we can expect from use of these agents. What are the potential clinical benefits? There's been speculation that they would be advantageous in people with chronic kidney disease because they would allow greater use of RAS blockade and we would get the benefits of the renoprotective benefits and the cardiovascular benefits of RAS blockade. Whether this in fact translates into clinical outcomes is yet to be proven. So in conclusion, hyperkalemia is associated with chronic kidney disease and other comorbidities, but the association with chronic kidney disease is the strongest. Both high and low potassium levels beyond the normal range are associated with mortality. SBS is associated with an increased risk of rare but serious gastrointestinal adverse events. There are many established management algorithms for hyperkalemia, and some of these are incorporated in the KDIGO Potassium Controversies publication. Many of the agents used in managing potassium have not been tested in large randomised trials, and most of the evidence we have to date has focused on the acute effects on potassium and not the longer-term effects on clinical outcomes. The role of routine potassium management in improving long-term outcomes should be demonstrated in large clinical outcome trials, and that would guide protocols in clinical practice. Thank you.